Imagine undergoing surgery, believing it's absolutely essential for your health, only to discover afterward that it was completely unnecessary. This isn't about rare surgical errors or a few rogue physicians. It's a systemic pattern that the medical establishment rarely admits. Operations are frequently recommended not because they are medically imperative, but because it's the established protocol, often faster, easier, and, frankly, because someone profits from it. As someone who has spent 15 years witnessing this play out in real patients, I've seen individuals walk into a clinic with a minor issue and emerge with a far greater one, their lives altered by decisions that should never have been made. It is my duty to speak this truth aloud. Today, I'm revealing 5 common operations I would never undergo myself, and which, in all likelihood, are equally unnecessary for you. The healthcare system, by design, doesn't profit from keeping you well. It profits from treating you. This vital information is unlikely to be shared during your next appointment. Let's begin with the first procedure: diagnostic laparoscopy. These two medical terms essentially mean a surgeon makes small punctures in the abdomen, inserts a tiny camera, and visually inspects the internal abdominal cavity. The diagnostic part indicates the goal isn't to treat anything, but purely to establish a diagnosis. In essence, you are undergoing surgery to figure out what's wrong. Let me detail the process, as these specifics are rarely explained. The surgeon uses a specialized clamp to grasp the skin near the navel, pulling it taut before driving a metal tube, known as a trocar, through the abdominal wall. This isn't a delicate needle. It's a hollow metal shaft with a sharp inner rod that punctures through the abdominal wall layers. Once the rod is removed, an optical device, the camera, is fed through the remaining tube into the abdominal cavity. The significant challenge here is that the abdominal cavity isn't an empty space. It's densely packed with intestines, a stomach, and a liver. To create visibility for the camera, carbon dioxide gas is pumped into the abdomen, literally inflating you from the inside. This expands the abdominal volume, sharply spikes the internal pressure, and pushes your diaphragm, the muscle separating the chest from the abdomen that controls your breathing, upward. Consequently, breathing becomes shallow and labored. If the surgeon needs to examine the pelvic region, including the urinary and reproductive systems, the patient is also tilted, with legs raised and head lower than the torso, a position utterly unnatural in ordinary human life. Consider the implications. Your abdomen has never, over your entire lifetime, been inflated under gas pressure from the inside. This is a completely non-physiological state. Your abdominal wall is stretched in ways it was never designed to be, and the ligaments supporting your internal organs, your liver, kidneys, intestines, are subjected to forces they were never built to withstand. Your ribs are pulled upward, and the pelvic floor, the muscular platform supporting pelvic organs, is compressed from above. When the gas is released and the procedure concludes, the abdomen returns to its original size, but the tissues retain a memory of the trauma. Stretched ligaments don't instantly snap back. For weeks, and sometimes months, afterward, patients report sensations difficult to describe: abdominal discomfort, a sense of heaviness, a feeling that something is simply off. These aren't formally recorded as complications because, technically, the operation went smoothly. Yet, the body remembers. Then there are the puncture sites themselves. In medicine, a fundamental principle states that any disruption of tissue integrity invariably heals through scar formation. The external scar, you see, is merely the surface. Beneath it lies scar tissue, in the muscle, the fascia, the dense fibrous sheet wrapping muscles and organs, and potentially in the peritoneum, the thin membrane lining the abdominal cavity. Scar tissue is coarse, inelastic, and pulls, often creating adhesions, fibrous bands that form between organs that should normally glide freely against each other. Adhesions following laparoscopy are not a rare complication. They are an expected outcome. The most frustrating aspect is that after diagnostic laparoscopy, surgeons frequently find nothing, or they discover exactly what was already visible on an ultrasound, or they identify changes requiring no treatment. The patient endured general anesthesia, abdominal punctures, gas inflation, and being tilted upside down, only for the result to be, everything looks fine, no pathology detected. A month later, abdominal pain often arises, a direct consequence of the procedure. My stance is firm. Diagnostic laparoscopy is acceptable only when all non-invasive methods, those involving no punctures or incisions, have been thoroughly exhausted without providing an answer, and when the clinical situation demands an urgent decision. Modern medicine offers high-resolution ultrasound, MRI with multiple contrast protocols, CT scanning, and comprehensive laboratory panels with a broad range of diagnostic markers. This is a powerful arsenal. Utilizing it fully and skillfully is the true art of the physician. Puncturing the abdomen is not a diagnostic act, it is diagnostic surrender. The second operation I wish to discuss in detail is the surgical repair of an umbilical hernia. Understanding the underlying mechanism is crucial here. A hernia is the protrusion of an internal organ, or part of one, beyond its natural cavity, pushed through a weak point in the surrounding wall. In an umbilical hernia, this weakness is in the front of the abdominal wall at the navel. Through this opening, a loop of intestine, or a portion of the omentum, a fatty, protective fold inside the abdomen, can bulge outward. Why does this weak point exist? It stems from an inherent weakness of connective tissue, the structural framework of the entire body, forming ligaments, tendons, joint capsules, blood vessel walls, and fascial wrappings around muscles. When connective tissue is intrinsically weak, these structures fail to bear loads effectively. In some individuals, this manifests as varicose veins, in others, hypermobile joints, and in still others, hernias. These are all expressions of the same underlying problem, connective tissue weakness, simply appearing in different parts of the body. Umbilical hernias are extremely common in newborns, affecting approximately 1 in 5 infants. After the umbilical cord is cut, the umbilical ring, the opening through which the cord's blood vessels passed, is supposed to close. For the majority of children, it closes spontaneously within the first few years of life. By the age of 5 to 7 years, the overwhelming majority of umbilical hernias in children have resolved entirely without any intervention. They simply disappear as connective tissue matures, muscles strengthen, and the umbilical ring closes naturally. Surgeons are aware of this, yet operations are frequently offered, sometimes to children as young as 2 or 3 years old. The surgical rationale has a certain internal consistency. A sutured ring certainly won't reopen. However, the real question is whether it needs to be sutured at all if it will close on its own. Every operation entails anesthesia, stress on a child's developing system, and a scar. Why accept all of this when nature can manage it without a scalpel? There are genuine situations where surgery is necessary, such as a very large hernia opening, technically called a large hernia orifice, through which a significant portion of intestine can pass. Another is the risk of incarceration, where a loop of intestine or omentum becomes trapped within the hernia, cutting off its blood supply and leading to tissue necrosis, the death of tissue. This is an acute emergency requiring immediate surgery. If a segment of intestine is already necrotic upon the patient's arrival, it must be removed and the remaining ends rejoined, a procedure known as intestinal resection with anastomosis, which carries far greater risk than a routine elective hernia repair. These are the cases where earlier intervention is truly warranted, but they represent a minority. The The majority of umbilical hernias, particularly in children, do not incarcerate and close spontaneously. My practical advice: if you or your child has been diagnosed with an umbilical hernia and surgery has been proposed, is not to rush. Ask the surgeon specific questions. What is the actual risk of incarceration? What is the measured size of the hernia orifice? Is watchful waiting a legitimate option? If the answers are vague, seek a second, then a third surgeon's opinion. If all three agree surgery is indicated, there are grounds for it. If opinions diverge, you have both time and choices. Now, for what you can actively do on your own, I recommend one specific exercise to every patient I see with any abdominal wall hernia: umbilical, inguinal, femoral, or linea alba. This exercise strengthens the transverse abdominal muscle, the deepest layer of abdominal musculature. It wraps around the torso like a natural corset, primarily functioning to hold internal organs in place and maintain stable, healthy intra-abdominal pressure. When this muscle is weak, pressure inside the abdomen doesn't distribute evenly. It concentrates at the weakest points, such as the umbilical ring. Here's the exercise. Stand upright or lie on your back. Slowly and as deeply as possible, draw your abdomen inward, literally pulling your navel toward your spine as far as you can. Hold that tension. While maintaining this contraction, try to deepen it further, pulling even harder, and then again. Continue until you feel a deep burning sensation in your abdominal muscles, reaching your true limit. Then, slowly exhale and fully release. Do this daily. Within a week, you'll feel your abdomen pulling tighter. Within a month of consistent practice, the effect will be visible. Women dealing with diastasis recti, the separation of the rectus abdominis muscles, often developing during pregnancy, report that with regular practice of this exercise, the separation begins to narrow, sometimes without any surgery at all. There's another mechanism worth understanding. Many abdominal wall hernias are linked to visceral ptosis, the downward displacement of internal organs. The intestines shift downward, pressing against the front of the abdominal wall from within, increasing pressure directly on the weakest points, the hernia openings. If the goal is to prevent a hernia from growing and avoid surgery, the root cause must be addressed. Strengthen the muscular corset and correct the organ displacement. This is achievable and effective. I've witnessed it work in my patients many times. Now we move to the third operation, and this one might surprise many of you, because I'm talking about an intramuscular injection. A shot. Is a shot in the gluteal muscle an operation? Yes. From a strict medical standpoint, it is classified as a minor surgical procedure. This is not a metaphor or an exaggeration. It's the official classification. By definition, any operation is an intervention that violates the integrity of the skin and underlying tissues. An intramuscular injection fully meets this definition, and, like every operation, it carries requirements for sterility, specific technical demands, and potential complications. Let me walk you through exactly what happens to the tissue with every injection. The needle enters the skin, passes through the subcutaneous fat layer, and penetrates into the muscle. Along this entire path, it cuts and displaces tissue, causing mechanical damage. Then, the medication is injected under pressure. It doesn't simply fill an empty space. It forcibly separates muscle fibers, creating a cavity in the muscle tissue, typically 1 to 5 milliliters in volume, depending on the dose. Once the needle is withdrawn, the body begins repairing the damage, and it does so the only way it knows how, by forming scar tissue. 1 injection, 1 scar. Small and functionally almost imperceptible. 10 injections, 10 scars. A course of 20 intramuscular injections, and the muscle begins to resemble something considerably denser and more rigid than living, elastic tissue. I worked as a nurse in an oncology ward, where patients returned for repeat rehabilitation courses involving long series of vitamin injections. Some developed gluteal muscles that became literally hard. Inserting the needle required noticeable force. This isn't colorful language. It's a clinical fact I witnessed firsthand. Oil-based solutions are particularly aggressive in this regard, including fat-soluble vitamins like D, E, and A, and certain hormonal preparations. A water-based solution is absorbed into the bloodstream relatively quickly after injection, but an oil-based solution dissolves slowly, sometimes very slowly. This means a foreign substance remains inside the muscle for an extended period, sustaining an inflammatory response. Inflammation eventually becomes scar tissue, and the scarring from oil-based injections is coarser, denser, and more functionally significant. Now, the complications. The mildest is local tenderness and palpable hardening at the injection site. More serious is an infiltrate, a firm, persistent lump of medication and inflammatory fluid that doesn't resorb on its own. Even more serious is an abscess, a pus-filled cavity inside the muscle. I worked in a department of purulent surgery and saw these patients. Their gluteal region had to be surgically opened, drainage tubes inserted to allow the pus to flow out, and they were unable to sit or walk normally for weeks. It all began with a seemingly harmless injection. Infection can occur even with full sterile technique, particularly in patients with compromised immunity, diabetes, or when circulation in the area is already impaired by prior scarring. There's one more rarely discussed risk: the sciatic nerve, the largest nerve in the human body, passes through the gluteal region, governing both movement and sensation throughout the entire leg. If the needle contacts it, the result is sharp pain, numbness, and impaired leg movement. In severe cases, permanent neurological deficits can occur. This is precisely why injections are given in the upper outer quadrant of the gluteal muscle, where the nerve does not pass. However, proper technique demands real skill, and not everyone possesses it equally. I've heard patients say, "One nurse gave me a shot, and I felt nothing. Another gave me one, and I was dragging my leg for 3 days." This isn't random variation. It's the difference in technique. The practical takeaway is simple. If a medication is available in tablet or capsule form, take it orally. The bioavailability, the percentage of the substance that actually reaches the bloodstream in modern oral formulations, is comparable to injectable forms. Vitamins in capsules work no worse than injections, and antibiotics in tablet form are equally effective as injections for the vast majority of infections. There is no reason to fill your muscles with scar tissue for an effect you can achieve without it. Injections should only be used where there is truly no alternative: emergency situations, compromised gastrointestinal function, or medications that have no oral form. The fourth operation is the surgical facelift, medically known as rhytidectomy. In simple terms, through incisions along the hairline and behind the ears, a surgeon tightens the skin and muscles of the face, removes excess tissue, and fixes everything in a new position. The goal is to smooth wrinkles and restore the jawline. On the surface, this is an appealing idea. In practice, it's an intervention with risks fundamentally different from operations performed on other parts of the body. Let's start with the scars. Every incision produces a scar. In the facial region, this means disrupted blood circulation along the entire perimeter of the incision. Scar tissue does not conduct blood as efficiently as healthy tissue. The skin nourished by vessels passing through a scarred zone receives progressively less oxygen and fewer nutrients. The result, that skin ages faster. Here's the paradox. An operation designed to fight aging actually accelerates it, not immediately, but over time. The second issue involves the unique muscles of the face. Unlike almost every other muscle in the body, facial muscles do not attach to bone. They attach directly to the skin. This is precisely why we can express emotions. We can smile, frown, and raise our eyebrows. These facial muscles are connected through a network of fascia, dense connective tissue sheaths, to the rest of the body, the jaw muscles, the neck muscles, and the trapezius extending down to the shoulder blades. This isn't theory. It's anatomy you can verify right now. Close your eyes and tune into your body. Scrunch your entire face with maximum effort. Eyes, nose, mouth, forehead, as tight as you can. Notice what happens in your neck, shoulders, and chest. There's a subtle but real tension response throughout the whole system. Now, completely release your face. Add a gentle half smile. Feel how your body drops, softens, and settles. This is not a psychological effect. It's physiology. The muscular chains connecting the face to the rest of the body are real and active. When a surgeon pulls and fixes the muscles of the face in a new position, they are altering the tension throughout that entire chain. The muscles begin operating differently, which changes head positioning, neck muscle tone, and posture. This influence is difficult to measure precisely, but it is real, and it invariably moves the system towards disruption, not improvement. The third risk is specific to the face: asymmetry. No human face is perfectly symmetric. This is completely normal, but it also means the muscles on each side of the face are in different states of contraction and length. This asymmetry shifts across different zones of the face, with the right side dominant in some areas and the left in others. A surgeon performing the procedure with technical perfection, doing everything geometrically symmetric, may fail to account for this baseline tissue asymmetry. The result can look unnatural: a tilt, one eyebrow sitting higher than the other, a corner of the mouth pulling to one side. These outcomes are not isolated cases. They are frequent enough to constitute a systemic risk. And the most important point, one almost never raised in the context of cosmetic procedures, is that your face ages harmoniously. Nature performs this process gradually, evenly, and proportionally. Wrinkles appear where the skin worked hardest, around the eyes, around the mouth, as marks of a life lived, a record of emotions expressed. They look natural because they are natural. There are people whose maturity is genuinely beautiful precisely because they did not intervene. When we intervene, even with the best intentions, we break that harmony. One area of the face might look 20 years younger, but the rest does not. That mismatch is always visible because the eye perceives any disruption of a natural process as something wrong. What works instead of surgery? First and most powerfully, circulation. The finest cosmetic in the world is your own arterial blood, which delivers oxygen, nutrients, and growth factors to every tissue. When blood flows freely to the face and drains freely through the lymphatic vessels and veins, the skin looks alive, firm, and vital. What blocks that flow? Muscular tension in the neck, poor posture, physical inactivity, and chronic stress that keeps muscles locked in a constant low-grade contraction. Second, facial exercises. They work. Here's a simple one. Place both palms gently over your face, covering your forehead, cheeks, and chin. Without sharp movements, apply a very gentle upward pressure, not a pull, but a directional lift. Hold this position for several minutes, then slowly remove your hands, maintaining that upward orientation in your mind. You might notice that on one side the tissues feel more yielding, and on the other there's slight resistance. That's the asymmetry. Work with equal pressure on both sides. With regular practice, the tissues genuinely begin to lift. This isn't mysticism. its stimulation of lymphatic drainage, and improved tissue nutrition. The fifth operation is cesarean section without medical indication. Let me be direct from the start. When the indications are real, this is a brilliant, life-saving operation. Cases like placenta previa, where the placenta covers the cervical opening and blocks delivery. A persistent transverse or breech position of the baby, creating genuine risk for natural birth. Or acute fetal hypoxia, when the baby is no longer receiving sufficient oxygen and minutes matter. In these situations, a cesarean section is life-saving. Without it, there would be catastrophe. I am not talking about those cases. I am talking about situations where a woman requests a cesarean because she doesn't want to go through labor, because she wants to choose the birth date, because she is afraid, or because a physician recommended it without specific indications, simply as a default or a precaution. Here's what happens to the mother. A cesarean section is a major abdominal operation. The front of the abdominal wall is cut open, and the uterus is opened. General anesthesia or spinal anesthesia, an injection into the spinal canal that numbs the lower half of the body, is required. The baby is extracted, and then the uterus and abdominal wall are closed in layers. A scar remains on the uterus permanently. In any subsequent pregnancy, that scar carries specific risks. Possible placenta accreta, where the placenta grows directly into the scar, and possible uterine rupture along the scar during labor, which is a life-threatening emergency. The abdominal scar is painful, sometimes for several weeks. Rolling over in bed, standing up, lifting the baby, all cause pain. I have heard patients say, "I thought it would be easier than natural labor." Then the anesthesia wore off, and I realized I was wrong. This is not an isolated story. It's a pattern I hear regularly. Post-operative recovery after a cesarean is substantially harder than recovery after a straightforward vaginal birth. After a natural delivery, a woman is on her feet within hours. After a cesarean, it takes a full day, and even then, with difficulty. Breastfeeding is also harder to establish because the hormonal cascade that initiates milk production is normally triggered by the physiological process of labor itself. Now, for the baby, and this is information most people simply do not have. During passage through the birth canal, a critical process called bacterial colonization occurs. The newborn receives the mother's own microflora, the bacteria that naturally inhabit the birth canal. These bacteria become the foundation of the infant's intestinal microbiome, its first line of immune defense. This is not theoretical. It is an area of active, rigorous scientific research. Babies born by cesarean section do not receive this primary colonization. Instead of the mother's beneficial bacteria, they receive whatever is present in the operating room environment. The measurable consequences include statistically higher rates of allergic disease, atopic dermatitis, a chronic immune-mediated skin inflammation, bronchial asthma, and gastrointestinal difficulties in early childhood. In addition, the physical compression of passing through the birth canal stimulates the baby's lungs in a way that helps expel the fluid that has filled them throughout pregnancy. This is the physiological preparation for the first breath. During a cesarean section, this does not happen. Infants born by cesarean more frequently require additional respiratory support, and their first independent breath is harder for them to take. Childbirth is the one area of medicine where learning from mistakes is categorically unacceptable. The cost of an error is the life and health of two people simultaneously. If you are planning a birth, or if there is a pregnant woman in your life, approach this with full seriousness. Find an obstetrician-gynecologist with real experience managing vaginal delivery. If a cesarean is being proposed to you, ask directly, what are the specific indications? What exactly, in my case, makes a cesarean necessary? If the answer is unclear, find another specialist. Here's something worth knowing from a purely clinical standpoint. every risk discussed today, the risk of scar formation, adhesion development, and complications following any surgical procedure, is measurably higher in people over 40 years old. After 40, connective tissue heals more slowly, scars form more densely, and the tendency to develop adhesions increases, which means the price of an unnecessary operation rises steadily as you get older. So, what should you do after watching this? First, do not make a decision about surgery in a single doctor's office on a single visit. Any elective operation is a decision that requires time and a second opinion. Ask your surgeon a direct question. What happens if I decline the operation? What changes in 3 months, in 6 months, in a year? If the answer is evasive, take a pause. Find a second specialist, then a third. Compare their positions. In parallel, explore conservative options, exercise, nutritional correction, physical therapy, and lifestyle modification. Many conditions routinely classified as surgical stop being surgical under a well-executed conservative approach. This is not wishful thinking. This is evidence-based medicine, and it is what I see in my practice. And remember one thing. Medicine has a principle that is short and powerful. Primum non nocere. First, do no harm. This is not a slogan. It is the foundation. The best operation is the one that turned out to be unnecessary. The healthcare system is not built to keep you healthy. It is built around procedures, referrals, and operating rooms. Nobody in a clinical setting is going to lay this out for you the way I just did.